Nearly 200,000 needless amputations occur every single year due to diabetic foot ulcers and peripheral artery disease. The highest rates are in the African American communities, especially in the South. And looking at a map published in a recent ProPublica article, the areas where amputations are the highest are eerily similar when compared to a map showing areas of slavery in the 1860s. Health discrimination is real, and you must speak up to save your life and your limb. To help reduce the number of needless amputations, highly skilled vascular interventionalists are infiltrating the most vulnerable areas, the rural areas, especially in the South, to help inspire patients to get treated sooner and to provide other options that are close by. Dr. Stephen Leshack is a managing director of Modern Vascular's newest practice in South Haven, Mississippi, and Dr. Wande Pratt, who will soon be managing director of the Modern Vascular office opening up this next year in St. Louis, Missouri. And they join us now in our keynote fireside chat, starting with leave the yes sirs and yes ma'ams behind and stand up for your health. Now, Dr. Pratt, I want to start with you. You know, healthcare discrimination happens for a variety of reasons, but my experience was in the South where I'd watched a skilled surgeon restore blood flow in some really complex cases. And then afterwards, he invited me to his clinic where he told a patient his only option was amputation. And I questioned him afterwards as the fluoroscopy images seemed to be pretty straightforward. I mean, at least comparatively to the ones that he had done earlier. And he said, quote, "I've already treated this man multiple times, and he is a Black man from the projects who won't take care of himself because he just doesn't have the means. So why delay the inevitable? We might as well amputate now versus later," unquote. Looking at the map I showed just moments ago, this is not unique. I really was disturbed by this, and it was one of the catalysts for me to start the Way to My Heart. Would you describe your view of this landscape, and why is it so important for Modern Vascular to have office-based labs in Southern Mississippi and in Missouri?
I think overall that a lot of patients are they are trusting of their doctors, and maybe, like you said, maybe a little too trusting sometimes.
Mm-hmm.
I do think that that's where you get into some, in my mind, some healthcare discrimination. You've got a lot of patients that they think that, that their doctor is right, but they don't know the other options. They don't know that there's, options to intervene. They don't know that their leg could be potentially saved. And I think that's what makes us unique, though, is that we give them that option, even if other doctors are going to tell them they can't fix it.
What about you, Dr. Leshack? What is your experience?
A lot of these patients are older. So in my experience, younger patients generally are more educated and have more access to the internet, and they're less trusting in their physicians. With the older patients, particularly in these depressed areas, don't just trust their physician. So whatever the physician tells them, they sort of go along with the program. So it's education. The patients need to educate. They need to become a consumer of their own care.
Well, healthcare discrimination is one reason for needless amputations. Another reason is also misdiagnosis and, unfortunately, no diagnosis until it reaches, or peripheral artery disease reaches, advanced stages. Some patients have actually told me they were never officially diagnosed with P.A.D until after their first toe amputations. Doctors just brush it off as old age, or when it comes to diabetics, neuropathy. And they offer pain pills as the quick fix. But what's really necessary is a long-term solution. So I want to discuss now the truth about neuropathy and how to know if it's P.A.D or if it's something else.
I think when it comes down to it, it's not something that is very easy for us to tease out. And I don't think it's easy for the patients to tease out. The symptoms may overlap when we're talking about neuropathy versus peripheral arterial disease. Mm-hmm. And then really be blended. You can have patients that have a component of neuropathy and a component of P.A.D. So it starts essentially, in an office visit, either with your primary care physician, your podiatrist, an endocrinologist, even a vascular interventionalist, vascular interventional radiology, or vascular surgeon. What we start with is essentially asking the patient key questions about their pain, trying to get a sense of when they experience pain, what are things that relieve the pain, what are things that exacerbate the pain, duration, location. Those are some of the key factors that we look for. But ultimately, the next step is going to be some type of diagnostic study. Unfortunately, our diagnostic studies aren't very good right now, to be frank, about
Really?
diagnosing and teasing out neuropathy. Absolutely. We still struggle with being able to tease out the difference between a patient with ischemic neuropathy or diabetic neuropathy. We struggle with that.
Can you talk
So I
about the
think-
differences between those two?
So diabetic neuropathy would be a patient who oftentimes has diabetes, and their pain is going to be a burning or numbness or a tingling type sensation. Ischemic neuropathy, often classified consistent more with breast pain or critical limb ischemia, can cause not only pain, burning, but also those ulcers that we can see in some patients. So there is another component that is associated with the pain and neuropathy that patients are experiencing.
What tests can you actually use to confirm? Is it possible to really confirm in a non-invasive way?
I think that's up for debate. I think the classification of neuropathy, it's an assessment. It's a collection of clinical manifestations. There isn't any test that I know of that can diagnose or determine whether it's diabetic neuropathy versus ischemic neuropathy.
It's really just getting to the point. And Dr. Leshack, you can feel free to weigh in here as well. If you want to test at least to see if it's a circulation problem, you could go, some doctors will, go to an ABI test, ankle brachial index, where they put blood pressure cuffs on your legs and your arms, and they measure the differential. But with patients who are diabetic, it could get a false normal. So the real test is an ultrasound.
The ultrasound will tell you if there's any disease in the artery specifically, stenosis or an occlusion. You still can have a normal ABI with a posterior tibial occlusion, one of the vessels going down the leg that's higher up than the ankle, and the TBI or ABI could be normal. With the neuropathy and the pain and that kind of ischemic pain, what I see is patients have inframalleolar disease below the ankle that won't be detected on ultrasound necessarily. So they'll have disease in that one artery and the loop, the plantar loop. And that, if you fix that, a good chance you can relieve a lot of their symptoms of rest pain, some of their neuropathy, but you may not necessarily pick that up on the ultrasound or the TBI. It's very difficult. I struggle with this because we do have a lot of patients come in with normal ABIs, normal TBIs, but when they're saying to me, I have severe nighttime cramps, nocturnal cramps, which is a form of rest pain, and they have neuropathy, but they really have normal studies. Unless you do a really dedicated ultrasound, you may not pick up some of the more subtle findings, proximal subtle findings, such as the narrowing, things like that. So I use the ultrasound as a guide, but it's not the end all be all. So it's difficult. It's a difficult study in these patients to really act on.
How would you determine, along with your patient, that now's the time to do what's called an intervention, where you make that little keyhole incision and you go in with wires and balloons and things like that to restore some flow in areas that might be blocked? And what questions should a patient ask their doctor to help them make that determination if now's the time and if that's the right course of treatment?
Well, I can tell you some of the patients that I've seen with diabetic ulcers, the classic diabetic on the underside, the plantar surface of the foot, have normal ultrasounds. Okay, so I've seen that. And those patients have inframalleolar disease below the ankle. If you have an ulcer, there's a pretty good chance you have some vascular component to that, high likelihood in a diabetic. So those patients, I will, no matter what the ultrasound shows, I will take those patients to angiography and at least look. And in most cases, I will treat those patients. There's something there going on. And if you fix that, you have a better likelihood of healing that ulcer. And that's my experience. I'm not sure if Wanda, You agree with that sort of assessment?
Yeah, I think it is a judgment that the interventionalist has to make, and the components that go into it begin with the patient. If the patient has symptoms that warrant some type of intervention, I agree with Steve. You have to go the next step, whether that's a diagnostic angiogram with a possible intervention, particularly because the ultrasound is going to be unreliable in those patients. But if the patient has no symptoms, I think being aggressive with a diagnostic study, even if the ultrasound is normal, you have to be very careful in those patients as well. I think, again, it's a judgment call. I think the interventionalist as well as the patient have to make that decision.
Now, if you don't have signs of the neuropathy or your doctor brushes it off without a P.A.D diagnosis and treatment plan, you mentioned the first indication that you may have peripheral artery disease is a sore on your foot or on your lower leg that just does not heal. For diabetics, you mentioned it's known as a diabetic foot ulcer, and 60% of P.A.D amputations are actually a direct result of undiagnosed, untreated or mistreated diabetic ulcers. Can you go into a little bit more detail about what is a diabetic ulcer and how does it differ as well from a venous ulcer? Two very different treatments.
Typically, a diabetic ulcer is an ischemic ulcer. It's typically an ischemic ulcer. It's usually well circumscribed, punched out. Usually occurs because of the mechanics of the foot, the diabetic foot, and the way that the foot changes mechanically. The ulcer usually occurs on the plantar surface of the foot. Well circumscribed, punched out. A venous ulcer is related to usually valvular insufficiency, long-standing venous insufficiency, and they are less well defined, usually associated with leg swelling, some skin changes, some erythema, usually occur in the medial side near the ankle. That's the classic venous ulcer, and clearly different treatments.
When it comes to these diabetic ulcers, the sooner you get some treatment, the better for many of these patients. A lot of times these patients wait till long, and that's why it's critical. It's like, hey doc, ask me to take off my socks.
Absolutely. I think the earlier we can address these problems as interventionalists, the better patients can do. And I'm convinced that for patients that have long-standing diabetic neuropathy, it's going to be harder for us to be able to treat them to see a significant improvement, because I think the neuropathy over time is going to be affected. The longer they've had that neuropathy, the harder it is for us to even make a difference when it comes to restoring the blood flow.
And Dr. Leshack mentioned a little bit earlier about the plantar loop, and it's something that I think is very important and when we talk to our patients who are diabetics and they end up with ulcers, we always tell them you have to have a pedal loop or plantar loop specialist on your team, because they're the only ones that can ensure that you're always going to be able to have that blood flow going to your toes. So talk about why some of these doctors think it's incredibly radical to go to the feet. I had a patient just the other day who said, yeah, my doctor said that that's too dangerous. My vessels are too small down there and I can't treat them, but no one can treat them.
I think it's the lack of understanding. I don't think they understand. Like I said, there's a difference between treating patients with claudication and treating patients with critical limb ischemia. It's an education. Physicians don't understand that the pedal loop is critical to treating critical limb ischemic patients. It's not critical in treating patients that have claudication. So unless you really understand that, they're not going to address it. It's just not going to happen. So it really comes down to education of the physicians that are treating vascular disease.
And it's also these patients, they need to be asking the tough questions of their doctors and also be willing. And this is what's sad, is that some of our friends with P.A.D end up getting tossed around from one to another, to another, to another. And it takes so long to wait for the next appointment or the next appointment that finally they're in so much pain that they're just like, you know what? Just cut off my leg. It's going to be less pain. I just want it gone.
We're in the business, I think, of trying to save limbs.
Yep.
That doesn't just mean the actual limb, but also giving patients and people an opportunity to feel their legs. Sometimes we've had patients, oftentimes that come into our office, they say that they haven't been able to feel the bottom of their feet for years. We do an intervention, as Steve described, reconstruct the pedal loop, and now they've got feeling back in their feet. They can actually feel when they walk. They can feel their shoes. They can feel what it's like to put their feet on the ground. And I think that goes a long way. And absolutely, we have to see these patients early on to be able to make a difference for them.
Patients are at the mercy of their primary care physician, have the luck of what I call the referral lottery as to whether they're referred to a general surgeon, to a vascular surgeon, or a skilled interventionalist. Hey, who am I playing golf with these days? Oh, my buddy over here is, treats blocked arteries. So, I'm just going to send them to that person.
Yeah.
Can you describe the different physician dynamics and skill sets and why it's particularly important to have a skilled interventionalist on your side and on your team?
Sure. With diabetics, it's different than patients that present with smoking. Patients may present with claudication. With diabetics, it's a really different process. And these patients are going to have disease below the knee and below the ankle. And you need to recanalize those vessels, and you need to have inline flow all the way down to the foot. And if you don't do that, if you really don't focus on that, you're really not going to make a major impact on wound healing and rest pain. And this is a different skill set. And I think about 10% of the country is doing this. There's only a select group of physicians that are doing this. And I think the training needs to be put out there to vascular specialists to really focus on this aspect of peripheral vascular disease. And that's really, you have to learn the skill sets of getting catheters and wires into the foot and really opening up inline flow to these ulcers.
And, I have quite a few patients. I hear this all the time. My doctor is the big title at this big name hospital, and why would I listen to this random doctor despite degree in an office-based lab versus this well-known hospital that sounds like they know what they're talking about? And, I trust them. I mean, how do we shift this paradigm? Because we know different. We have those numbers. I look at the CMS data, the database. I know who amputates and who doesn't, and I know who does most of the amputations. So how do we shift this paradigm for patients when selecting a doctor so they're no longer using title and credential, but instead proven skill set as their primary measurement?
I think it's a difficult problem because, it's a perception is reality. I mean, you look at a Vanderbilt or a Harvard, you say, well, it's Harvard, it's Vanderbilt. They don't understand. I had a physician that thought about coming to our practice, was at Northwestern, and he came out to watch one of our physicians in Arizona, and he said to me, I couldn't believe it. And he goes, I'm on the speaker circuit. And he could not believe that one of our physicians could recanalize multiple vessels going into the foot. And he said, I was really impressed. He told me, he said, I'm on the speaker circuit, and maybe 5 or 10% of the country is doing this. There's not many people doing this kind of stuff. So it really needs to be education to the community and outreach. And part of it's on us. We need to educate our referring physicians, our podiatrists, our internal medicine people, what we can do. A lot of these physicians say, okay, well, he's a vascular. They all think we're doing the same stuff.
Right, they do.
And to tell somebody we're recanalizing the foot, I mean, look, these internal medicine physicians aren't going to understand that. They don't understand that. So a lot of it comes down to really educating them, and also they need to see the results. So when we're healing ulcers, we're fixing their foot pains, their patients are going back to their primary docs and seeing that, that's our best advertisement. And that's the only way, because it's like anything. You hear Harvard or Vanderbilt, or you hear these big institutions, that's what people are going to think. They just don't know. And it's got to get out there. And it's as part of it, your organization gets the information out there, but we need to sort of get it out there by our results.
Yeah, I think the patient should take it upon themselves, if they can, really to ask that provider detailed questions. How many of these have you done, or what's your familiarity with this procedure? What are other procedures that you think are effective? because you don't necessarily want the person who's got 30 or 40 or 50 journal articles, but only does 1 or 2 of these a year. And I think the providers, certainly at Modern Vascular, we do a lot of these every day, and every week we're doing a lot of these procedures. This is something that we see with a lot of frequency, so we're able to tease out some of these nuances. And I think if you're a specialist, you've got all the journal titles, you've got all the publications, you've got all the speaking engagements, but if you only do 1 or 2 of these a year, you're not really a specialist when it comes to treating these types of problems.
Well, I really appreciate you both, and we really appreciate having Modern Vascular and all of your Peter Loop specialists opening up new facilities in areas they need them most. So thank you so much.